As people are joining us, I just want to say that I am Dr. Gillian Goddard. I am an endocrinologist and the author of the Savvy Patient Substack. And today I am going to be answering questions from you all that you had regarding women's hormonal health. If you have any questions that you did not send to me in advance, you can go ahead and put those in the messages at the bottom of the screen. But in the meantime, I'm going to get started with some of the questions that you all sent me in advance. So the first question, we talked a while back about calcium and the importance of calcium for all women, but also in particular for women over age 50. And the question that I got from one of you was a question about how many women are actually consuming 1,200 milligrams of calcium per day, which is the recommended amount. And we'll get into that a little bit more in just a second. And if you're not consuming that, what are some ways to do that and how to think about supplementation, what types of supplements and when to take those supplements. So the initial question was sort of how many women are actually getting 1,200 milligrams of calcium a day? And I think it's important to go back here and explain that first of all, explain what the recommendations are. So for women up to age 50, the recommendation is to get 1,000 milligrams of calcium per day, and ideally in the form of dietary calcium, meaning you're eating calcium-containing foods. Once we hit age 50, that recommendation goes up from 1,000 milligrams a day to 1,200 milligrams a day. And the reason for that is related to maintaining bone density as we head into perimenopause and hoping to stave off osteoporosis and to reduce our fracture risk. So the truth is very few women are actually getting a full 1,200 milligrams of calcium only from dietary sources. So the average calcium consumption, daily calcium consumption among women in the US is right around 850 milligrams of calcium, which quite frankly is better than I would have thought. But that is what it is. And so even younger women are not necessarily meeting the recommended amounts of calcium purely from consuming calcium in your diet. When we look at sort of how many women are actually getting to the 1,200 milligrams, about 10% of women under age 70 are getting a full 1,200 milligrams of calcium in their diet. And then once we get over age 70, so women, quite frankly, who are at the highest risk of developing osteoporosis and at the highest risk for fracture, fewer than 1% of those women are actually getting 1,200 milligrams of calcium from their diet. So I think it's helpful to think about foods that are calcium containing that are not dairy. One of the biggest issues I think with women getting adequate calcium in their diet is that in midlife, many women become lactose intolerant. And so a lot of, calcium containing foods, we automatically think of dairy, we think of cheese, and a lot of times our guts don't necessarily allow us to rely on those foods. And so then the question becomes sort of, what are all the other foods that contain calcium that we can kind of add to our diet to beef things up? So one of the best foods for calcium is actually salmon. Salmon's a great source of calcium. Almonds are an excellent source of calcium. Black beans are an amazing source of calcium. Oranges are a decent source of calcium. And then green leafy vegetables are a fantastic source of calcium. And then my favorite, actually, that you can actually get absorbable calcium from mineral water. So you can't tell from this glass, but this is Pellegrino. And it is one of my favorite ways to get calcium. In an 8-ounce glass of Pellegrino, you can actually get about 5% of the daily recommended calcium. So there's lots of different options for getting calcium. But the reality is that it is difficult to get all 1,200 milligrams in your diet, which is how we end up talking about supplements. Um, supplements, uh, they come in a few different varieties and flavors. But what I typically say is you can assume you're getting about 600 milligrams of calcium a day from a supplement or from your diet. You can assume you're getting about 600 milligrams of calcium a day from your diet. And so then you would want to think about, especially after age 50, another 600 milligrams in the form of a supplement. And I think that there's a lot of confusion here. The two most common types of supplements are calcium carbonate and calcium citrate. Calcium carbonate is the cheapest form of calcium supplement. The challenge is it can cause some gastrointestinal upset and some constipation. It also you have to have acid in your stomach to break down the molecule and absorb the calcium. And so if you're someone who takes medications for like heartburn or reflux, you cannot break down calcium carbonate to absorb the calcium. That also means calcium carbonate is best taken with food, which in many ways can make it easier to take. Calcium citrate is the next most common form. It is easier to digest and easier on the gastrointestinal system. Unfortunately, it's also a little bit more expensive, but it can be a great option. It, on the other hand, does not need acid, and so it can be taken on an empty stomach. The other question is sort of how much calcium can we absorb at any given time? So, calcium carbonate needs to be taken with food, but if you're taking a calcium carbonate supplement and you're eating a calcium rich meal, are you absorbing all of that calcium? And and the answer is probably no. We probably are able to absorb about 5 to 600 milligrams of calcium in one go. And so I think that this is another way in which calcium carbonate can be a little bit of an easier supplement because you don't feel, if you're trying to eat a calcium rich diet, you don't feel like you're losing some of that calcium carbonate because you're eating it with a calcium containing food. Um, to some degree, I think that we need to realize that the studies that um, were done on real women who were kind of consuming what they recorded that they were consuming. So what do I mean by this? There's lots of discussion about like what's absorbable. Calcium from green leafy vegetables may not be as absorbable as calcium from dairy products, for example. But I think what we need to focus on is that when people are doing studies, they're recording the amount of calcium intake. They're not necessarily estimating how much of that calcium is getting absorbed. And so let's not let the perfect be the enemy of the good here. Um, I think do your best to get as much calcium as you can from your diet. Do your best to get in a supplement. Are you going to absorb every last milligram of calcium? I mean, probably not. But the reality is if you're really making an effort, you're likely going to be just fine. Um, and so and so kind of getting into the nitty-gritty of like how much are you actually absorbing from different foods is something that is not necessarily represented in the data and is not represented in the guidelines. And so I think you can take the guidelines at face value, what you put in your mouth, goes toward that 1,200 milligrams, and you don't need to worry about what's most absorbable from that perspective. The key is really just making sure that you're getting the diet and probably in most cases the supplement, particularly after age 50. And so hopefully that was helpful. Um, it is one of the few when we think about sort of we tend to lump together things like iron and calcium and B12, which are vitamins and minerals, with supplements. Um, and so, when we think about sort of the recommended supplementation, calcium, a mineral, goes into, we often lump those things together in our head, which is a good transition into our next question, which is related to a true supplement, which is sort of a food or a food extract that people take for health. And the question here was from a reader who said, her mother was starting to experience some early signs of memory loss. And that many of her friends had started taking a particular supplement called Prevagen. And was that something that was recommended, and what did the data say about a supplement like Prevagen? So, to give you some sense, Prevagen is a contains a substance called apoequorin, and that substance, it was originally derived from jellyfish, and it binds to calcium, and is supposed to support memory function. Um, Unfortunately, what there is very little data to support the idea that this supplement is actually beneficial in warding off dementia. There's actually some studies that look how um, at how well this particular supplement reduces the proteins that are associated with dementia. And it really does not show um, a significant improvement in those protein levels, which are considered sort of a surrogate for the development of dementia. But I think what's important here, and what often gets lost in the conversation, is sort of the difference between how supplements come to the market and what the requirements are for supplements versus things like medications. Sorry, guys. Um, so supplements are not regulated by the FDA as medications. Supplements are regulated as food. What that means is that the manufacturers of the supplements do not have to prove that the supplement is effective. They actually don't have to show that what they claim the supplement does, it actually does. When it comes to medications, the pharmaceutical company has to prove that the medication is both safe and is more effective than typically a placebo at treating the the symptom or the disease that the pharmaceutical company is asking the FDA to approve the medication for. Supplements, they just have to show that there's nothing in the supplement that's harmful. It just can't contain harmful substances the same way any food on the shelf can't contain harmful substances. Annie's mac and cheese goes through the same process that these supplements go through from the point of view of the FDA, and the FDA doesn't view Annie's mac and cheese, and Provigen as being different from one another. That also means that they don't have to substantiate any of the claims that they make in their advertising. And this is why you will never hear me say, or okay, maybe never. I don't like to say never. This is why you will likely not ever hear me say that I am recommending a specific supplement. Typically, supplements do not undergo rigorous scientific testing, and and you don't know what you're getting, and you don't know if they really do what they are saying they are doing. That is different than a vitamin or a mineral that in particularly when you are treating a deficiency. So, if your doctor says that you are iron deficient and you need an iron supplement, that is a completely different issue and a completely different claim. Iron is a mineral. If you do not get enough iron in your diet, you can become deficient and you need to supplement your diet with additional iron. And so I think it's important to separate out the vitamins and minerals from sort of the supplements making claims around specific efficacy. So thank you for that question. And I'm sorry to disappoint, but Prevagen is not a supplement that I would recommend for staving off the symptoms of Alzheimer's disease. Um, Thank you so much to everyone who has joined us. For those of you who have joined us more recently, I am Dr. Gillian Goddard. I am the author of the Savvy Patient podcast, of the Savvy Patient Substack. And I'm here answering your questions. If you have any questions for me today, you can go ahead and put those questions in the messages below. And in the meantime, I'm going to keep answering the questions that you all sent to me previous ahead of this live. And I'm moving on to a question about testing. And this gets at another really important concept when we think about medical decision making. Um, so this person writes that they have a strong family history of cardiovascular disease. So they have a family history of stroke, high blood pressure, and heart attack on both mom's side of the family and dad's side of the family. And she's healthy. She's 39, so we're going to presume that she is premenopausal. And she's asking about doing a specific type of cholesterol testing called an ApoB blood test. And that test tests for a specific type of particle that has been a cholesterol particle that has been associated with an increased risk for cardiovascular disease. And I approach this question the way I would approach any question about doing a specific test. And I guess I don't go through this whole process every day, but every time I order tests on my patients, this is sort of the thought process behind it. And the number one question you should ask before you do a test is what will you do with the results? So, in this particular case, the test is not covered by insurance for this patient and can be quite expensive. And so, even more so in that case, but always, if we are doing a test on a patient, if you are the patient and you are having a test done, you should know what you will do with the results of that test. So, if the test will impact whether or not, in this case, you start a medication for cholesterol. Um, so let's think through this. I think it's helpful to think through, you know, what we would do with this. So the patient is healthy and 39 years old. So generally speaking, women premenopausal women, and again, this patient didn't say, or this reader didn't say specifically whether she was premenopausal or not, but given that she's 39, we're going to assume she's premenopausal. Um, premenopausal women are at very low risk for cardiovascular disease. So much so that we don't typically start statins in premenopausal women, except in very specific situations. So, statins are the most common type of cholesterol lowering medications, and they're sort of our first line medication choice when someone is at increased risk for cardiovascular disease. This reader didn't say how old her family members were when they had their cardiovascular events. But typically, if you are a premenopausal woman and your family history does not include someone who had what we would consider premature cardiovascular disease, so an event before a certain age, then we typically would not, we would say that your risk would be similar to other women your age and that your risk increases later in life. So, premature cardiovascular events are events that occur before age 45 in a man and before age 55 in a woman. Typically, men experience cardiovascular disease. Their risk increases about 5 years or excuse me, about 10 years before women's risk increases. And that's because of the effect of estrogen. Estrogen is very protective against cardiovascular, um, and against the development of inflammation in the arteries and plaque formation. And so, from that perspective, we would say this patient is very low risk. And so, the likelihood that we would start a statin is very small at this point, um, unless she has this family history of early disease. If the cholesterol levels are either very, very high, in which case we would probably recommend a statin earlier, or very, very low, um, where we might not recommend a statin at all. Usually ApoB is a test that we use to kind of as a decision maker. And so, what I would say in this case is I'm not sure that having that result, in fact, I'm pretty sure that having that result would not change our recommendations for a statin in this person at this time. The time to sort of reassess for this person would actually probably be in about 10 to 15 years, sort of around menopause, when we start to think about managing risk in the postmenopausal years. And that is when we would most likely be considering treatment, typically with a statin, although in 15 years, who knows, we might be using something completely different. And that is when we would really think about trying to further risk stratify this otherwise healthy patient whose main risk factor is family history. And so right now, I would say save your money. And things may be more clear when when you are postmenopausal, and that's when I would think about some of these tests that help to further risk stratify you based on your specific biochemistry. So I hope that that's helpful. Um, if anyone has any questions they want me to get to today, you can go ahead and pop those questions in the messages. Otherwise, I'm going to go ahead and address one more question that I've gotten recently from a patient, and this is a tricky one. This patient has been having some blood sugar issues. She's in her 40s and she had a high fasting glucose on a recent blood test. So, a lot of times when you go just for your regular physical, one of the things that your doctor will do is a chemistry, which includes some electrolytes, but it also includes a glucose. Um, and we have guidelines for what your glucose levels should be. And we have very specific fasting glucose guidelines. So a normal fasting glucose is between 70 and 100, although I will tell you some people will have lower fasting glucoses than 70, and that's okay. Um, a fasting glucose between 100 and 126 is considered pre-diabetes, and a fasting glucose above 126 is actually a diagnostic of type 2 or of diabetes. Could be type 1 or type 2, but in adults in midlife, we are usually talking about type 2 diabetes. So this patient had a fasting glucose that was slightly elevated. She um, then had some further testing, but she essentially has pre-diabetes, and she started wearing a glucose monitor and has made some changes to her diet. Her blood sugars during the day after eating are starting to come down, but her fasting blood sugars are not. And she's asking how long it will take for those fasting blood sugars to normalize. And I think that this is really important um, to think about because what regulates our blood sugars when we are fasted is completely different from what regulates our blood sugars when we've eaten. They're two different phenomenon, impaired fasting glucose and impaired glucose tolerance. Impaired glucose tolerance is um, when you don't actually your blood sugars go high after you eat because you're not metabolizing the sugar well. Impaired fasting glucose is actually controlled by your liver. And in people with insulin resistance, one of the things that is resistant is your liver, and your liver does not respond appropriately to the fasted state. It releases too much stored glucose. And so instead of releasing enough stored glucose to keep your blood sugar at 75, your liver starts increasing that number a little bit, a little bit, a little bit, and eventually it gets up over 100. That is actually not a phenomenon that we have a lot of control over from a diet and lifestyle point of view. Um, Improving glucose sensitivity in general may improve your fasting glucose over time, but that would be over an extended period of time. When someone has a persistently elevated fasting glucose, this is actually a time where I will consider medication. Um, Depending on many factors about the patient in general, um, this is a time there's a medication called metformin. It was originally developed to treat type 2 diabetes. Um, and it's an oldie but a goodie, and it's cheap. And one of the things that it does well is improve fasting glucose. The other thing it's been shown to do is reduce your risk of progressing from prediabetes to diabetes. And if you are a woman who has been pregnant and had gestational diabetes, it has been shown to be incredibly effective at reducing your risk of progressing to type 2 diabetes if you are starting to show these signs like an impaired fasting glucose of having dysregulated glucose metabolism. So this is a situation where I would have a conversation about what can realistically be done with diet and lifestyle, and what is really about how your body functions and would and sort of where medications may actually confer a significant benefit. Um, and so we might think about medications. One of the challenges here is I think people focus too much on the role of lifestyle in the development of type 2 diabetes, and not enough on the role of genetics and our own biochemistry on the development of type 2 diabetes. Um, Genetics plays a huge role. Genetics plays a huge role. And we, as of yet, cannot change your genes. And so it is not a failure to not be able to lower your fasting glucose. It is just a sign of how your particular body and liver work. Um, and and so availing yourself of the medications that are out there um, is a very worthwhile thing to do. Um, let's wrap up and talking about GLP-1s. Um, okay, so the question is how do you think about the increased risk of diabetic retinopathy and eye issues with GLP-1s? My family has a history of retinal issues. Okay, so I think there's two separate pieces here that we need to think about. Um, there is a piece that is diabetes related, and there is a piece that is GLP-1 related. So let's start with the diabetes related piece. When people have very high blood sugars, poorly controlled type 2 diabetes, I'm not talking about like the well controlled diabetic. I'm talking about the person who routinely is having very, very high blood sugars. When you put them on a medication and you lower their blood sugars rapidly, you can see retinal changes as a result of that rapid glucose lowering. There may be lots of other really important reasons to lower their blood sugar quickly. And so that doesn't mean we shouldn't do it, but it does mean that when we put people on effective treatments for their blood sugar, they may see some eye changes. And it is really important to monitor their retinal health with a retinal specialist. And so I always try to make sure that my patients with very high blood sugars, as we're lowering their blood sugars, are seeing their ophthalmologist regularly, and that they're really plugged in there, because we know that it's important to lower your blood sugars effectively. And we also know that it can have this unintended retinal side effect. So that's one piece. The other piece, and P.S., the reason I mention that is because people often blame the medication in those situations, and GLP-1s are incredibly effective at lowering blood sugar. They're a great treatment for type 2 diabetes. And so patients will often blame that um, and not they'll blame the medication and not realize it's related to the lowering of blood sugars. Um, The other piece is this report of optic neuritis, which is different, um, related to GLP-1s. Optic neuritis is not retinal; it's actually in the optic nerve, um, and and there are a couple of different conflicting studies about whether specifically semaglutide increases the risk for a very specific type of optic neuritis. This is super, super, super rare, and the studies are conflicting. There's one study that says that yes, GLP-1s are associated with an increased risk. There's one study that says that no, that they're not. I would say that the risk of this type of optic neuritis is so small that the benefits of GLP-1s far outweigh these really tiny risks. So much so, I will tell you, I have a patient. She never got a definitive diagnosis, but she may have had this particular type of optic neuritis. And even the neurologist or even the ophthalmologist who was a specialist in this, who she was seeing, okayed her going back on the GLP-1 um, and waiting and seeing what happened. Um, Obviously, the patient had to be okay with this too, but I think you have to remember that rare things are rare. The benefits of these medicines for a certain subset of the population are proven to be quite large. And so we want to not overblow the little benefit or the little downside when we're talking about potential huge upsides. That said, I think this is one of the things we need to realize that, these medicines are not risk free, and we should really be focusing on using them in the subset of the population where they've been shown to be beneficial, which is in people who have obesity or overweight, and comorbid conditions, and not in people who are just looking to lose a small amount of weight for more cosmetic reasons. Um, Nita has a question. Is having a high fasting glucose bad for your body long term? Mine has pretty much always been around 100, and I have a strong family history of diabetes, and I'm currently pre diabetic. So, what I would say is the high fasting glucose itself is not bad for your body. The high fasting glucose is an indication of how your particular body is processing glucose. And so it's it's not the high fasting glucose itself that is problematic for your long-term health. It is that it is a sign that you have inherited, and you said you have a strong family history of diabetes, that you have inherited a body that can, aspects of glucose metabolism in your genes that make you predisposed to developing prediabetes and diabetes. So it's almost more like a genetic marker for your risk for diabetes, which I would say is high. And so the reason we want to address impaired fasting glucose and prediabetes is not because they themselves are harmful, but because they indicate that you are at high risk of developing type 2 diabetes, which we know is harmful. The other thing I think is important to think about is that when we talk about blood sugar, we often talk in these categories, and we are categorizing what is essentially a continuous variable, right? So there is not necessarily something magically different about someone with a fasting glucose of 99 and a fasting glucose of 100. One does not mean that you're totally fine and have no problems whatsoever. And all of a sudden, when you pop up over that, that one little milligram per deciliter of sugar, you are suddenly at increased risk. It's that we have to, like medicine, and when we do studies, we have to put these sort of benchmarks in order to be able to draw any conclusions. And and so I think we need to think a little bit more flexibly about how we consider these things. The same is true of prediabetes versus diabetes. When we think about the measure hemoglobin A1C, which is another way of measuring blood sugar, you know, 6.4, you have prediabetes, 6.5, you have diabetes. The reality is they're not markedly different. And so we need to kind of think about this all more on a continuum. There's not a magic point necessarily at which treatment makes sense, but the real answer to your question is that um, impaired fasting glucose is really a marker of your risk, and not that impaired fasting, and not that that blood sugar at 100 when you're fasting in the morning is doing harm to you in that moment. And so I hope that answer is helpful. I think that one of the important things about this conversation about impaired fasting glucose, one of the things that's so important about this conversation is that our medical system is very focused on treating disease. And this is one of the ways that we can be proactive about managing risk as opposed to waiting for you to develop a disease that needs to be treated. But that's also why we have this idea that if a number is in a certain range, it's that number is in doing harm. It's really that it's indicative of something else. And so I hope that's helpful. Um, I'm going to wrap this up for today. Thank you so much for everybody's questions and for your engagement. I always enjoy getting your emails and seeing your questions here. Thank you to everyone who joined me. My next Substack Live is going to be in a few weeks in April, and I am going to be having a fitness expert and personal trainer joining me that day. And we are going to be talking all about exercise in midlife and what we all can do and how we can think about being fit. And so, I'll be sharing more about that timing with you all, but I'm really looking forward to that conversation. As always, please send me your questions. You can send those questions to ask at thesavvypatient.com, and I will answer as many as I possibly can. I'll see you all soon, and everybody have a great rest of your day.